Yeah, it is turned off now.
Good.
Let's see. It should be working also on the Instagram now. But
Yeah,
let's see if that's
I can see it on Facebook.
on Facebook and on Instagram also.
Let me just check.
Let's see if we're live on
Yeah, it's live.
Instagram.
It's live.
On Instagram also.
Yeah, I can see it here.
All right, that's good then. Oh yeah, that's true. Okay, great. All right, welcome everybody to this second live stream. Now about with the Trust Me team. It's a group of podcast hosts who are helping me, and we're going to discuss about manual therapy today. Of course, it is an interesting topic, a little bit controversial maybe, or maybe not. Depends who you talk to. Um, yeah, it is an. Let's have an open discussion and let's see what we think, and what we can learn from each other. And yeah, let's do it. If you have any questions or other thoughts, you can write them then in the chat. Not on Instagram, I think, but Facebook, YouTube, that works. Um, yeah, and this is a live stream where we have just open debates, and we can learn from each other. We don't have to be agreeing with each other every time, but because on social media it's a bit difficult to agree with each other. It's always like black and white, and let's try to get some nuance in here. All right, we have some questions prepared.
Yeah.
Let's first define manual therapy. What is manual therapy actually? What do you think, Bogdan?
Well, yeah. Hello to everybody. It's very nice to be back, and definitely it will be an interesting topic to talk about. Well, if you look at the words, it should be something that the therapist uses it's his hands or other body parts, but we should, in my opinion, and not only my opinion, I talk this with a lot of physios nowadays, manual therapy moves forward, so it's not only hands-on treatments. It should it and it is for a lot of physios. It's the whole assessment with the history taking, listening to the patient, creating hypothesis about the dominant mechanism of the patient's symptom, and really testing your hypothesis. And then you can use hands-on techniques, and definitely you should prescribe exercise that try to replicate your techniques. So it's not about putting things into place. We know that this doesn't happen. We have a lot of studies about this. It's just getting people to move, and some people just may be so sensitized that you cannot obtain it directly through an exercise, and you have these techniques that help you get there more faster.
For sure. What do you think, Faras?
Hi guys, hope you're doing well, enjoying your weekend, wherever you may be around the world. Yeah, I think Niels, you said it in your opening sentence. This is a very controversial topic, and it has been for probably 5 to 10 years now. Look, I'm not against manual therapy at all. I think manual therapy does have a place in physiotherapy. It has for years. It will continue to have a place in manual therapy, but we just have to be a little bit careful how we explain the narrative to our patients when we are treating them. But most importantly, I would like to say about manual therapy that a good physiotherapist is not defined by his hands. There's a lot more to a physiotherapist than just the hands-on techniques that a physiotherapist may or may not use in clinical practice. So I think that's what I would like to highlight to our audiences. especially our younger members and students and fresh graduates who have been told in university that this particular technique will solve this particular problem. I want you guys to understand that a good therapist is never defined just by his hands. There's a lot more whole-rounded, holistic approach to a physiotherapist that makes him a good physiotherapist. And that's what I like to say in my opening statement about manual therapy.
Mm-hmm. Let's see if the connection with Dan is a little bit better now. What do you think, Dan?
Hey guys, I blame it on Australia. I guess I'm a third year graduate. I've practiced, so perhaps sometimes it's important, in my opinion, to use a bit of manual therapy. I think we can all agree on that. Soft tissue work, whatever you like to call it. I think what Faraz said all bog right, but about if we use words such as you can create a bit of a debate to us. So I think the patients is very, very important. Talked about using exercise done. I think that's a very important. I like to use manual therapy to train. I feel like I could use my hand so that the patient can say and build that therapeutic alliance. I think important in what we do. So all manual therapy, but to the patient.
Mm-hmm. Yeah, your connection is not the best. It was a bit similar as last time, and somebody says it also in the chat indeed. Yeah, let's fix that for next time with the Aussies. That's that will be a better one. Yeah, so manual therapy is of course very controversial because you think I've had so many experiences also with people who came from other manual therapies who only want to have manipulations and only want to have massage, don't feel like they are empowered. They don't want to do anything else. They have pain, so somebody else has to do it. So external, how do you say it again?
Factors, external factors.
External factors, and you want to have somebody else fixing you. Yeah, that's all right then. Somebody else fixing you instead of that you know what is going on because the physio has taught you that, explained it well for you, and then this is explain it well to you, and then you can do something yourself, like exercise or movement, or try to use different postures and stuff to try to not go into that irritating posture. Yeah, I think that is or yeah, posture. I think that is more important. What do you think, guys?
Yeah, I think this is how I see things in general. This is part of my vision. Um, there is now a lot of against manual therapy, but to really understand a topic or a subject or an idea, you should really go deep in studying in it. Definitely, we're not defined about our handling skills because this is something that really varies because you can have your level of handling. It's Monday morning when you had a very nice weekend. It's different from a Friday afternoon. So this really varies. And you cannot, like Faraj said, you cannot really be defined by it. But then what I would say for the people that say that it doesn't really work is if they really studied it, because if they just did like in the university, and this is really we know that we don't have a consistency in the university curriculums about manual therapy, and then there are different schools of manual therapy, So it should be like we can to really understand the subject, you should really study it, and then you can say, okay, this doesn't work. And then it also comes to, we all have our favorite diagnostic, we all have our favorite techniques, and we know that when we really believe in what we are doing, this really creates an effect like a therapeutic placebo. And it can be really helpful. If you don't really believe in your technique, then we know, like Faraj said last time, uh, patients, if they believe they'll get better, they will get better. But also, if we believe that our technique is good, sometimes it has a better result.
For sure.
Yeah, I'd just like to add to that point that Bogdan has said. I mean, if we go back to, there was a post back in 2020, I think it was Physio Network who did it, and there's 10 commandments of physiotherapy. And I think number 6 or number 7 was manual therapy. And it says very, very clearly that I shall use manual therapy in brackets, if appropriate, close brackets, if it helps the patient move better. So that's what I say. I'm not against manual therapy. I think if it's used appropriately in the right way, and it doesn't, like Neil said, that the patient doesn't become reliant on it so much. For those 5 sessions, I'm going to come, I'm going to lie down, and the therapist is going to fix me. If we use maybe 1, maybe 2 sessions of manual therapy, and then the other 3 sessions that they've been given by their insurance or that what they're paying for is used to help them move better, to empower them, to make sure that their bodies are resilient and more robust, and we promote those sort of positive mind frames, then I think manual therapy can help getting the patient on our side, building that rapport and that trust, which is obviously very, very important because they trust you as a therapist to help fix them, as we say. But my point always is the narrative. If we stop using these kind of words, that I'm going to release you here, I'm going to stretch you here, I'm going to put you back in place here, those sort of things are detrimental to manual therapy and then overall to physiotherapy as a profession.
That's very true. Do you have a certain way of explaining manual therapy to your patients?
Manual therapy, what I say to my patients is very, very simple. We're going to use possibly some manual therapy techniques to reduce your pain in terms of maybe neuromodulation or transient effects. But this is not the be all and end all. We must reinforce this with some form of movement therapy or exercise so that when you leave this room, you walk out that door, you're on your own. I'm not there to put my finger inside your shoulder or stand there like this on your lower back. You need to go and do some exercises yourself. So I think explaining that transient change in some soft tissue structures is what manual therapy can do. We can maybe provide some neuromodulation or pain modulation, but that's about it. That's what we can't be specific. And that leads us on to obviously our next point of discussion, which is obviously the pros and cons of, I guess, manual therapy. And for me, we all know that research is very clear that we can't be very specific with our manual therapy techniques, although we are taught differently in university that we are moving the L4 and we're going to do a grade 3 PA movement on the L3, L4 facet joint. And we simply know that that's not true.
For sure. Do you have an explanation to your patients, Bogdan?
Yeah. Well, I really drive through assessment to see what this patient knows, and what does he believe in it, because we have now a lot of big information also in our countries, and we have different specialists, and we had a lot of time coming, like chiropractors from the east part, from Russia, for example, and we have a lot of patients that really believe that, oh, I came to you to put it back into place. My disc slipped, or that joint is not into place, and you must align it. And sometimes with these patients, I use phrases like, okay, um, you are in a sensitive state. Definitely, you need movement, but we're going to do it in a gradual way. And the first step in this gradual exposure to it, it will be like some passive things. And I'll do these passive techniques to you. I will show you, maybe I will give you some things that you can do it by your own, like some mobilizations with movement. and then after, it depends on patient, after one session, two sessions, three sessions, I don't know, five sessions, it depends on the patient. I will just say to him, look, now you're doing that technique on your own through this exercise, and this really gives an empowerment to the patient. So it's like the first step. I always call, like, it's the first step, but then you should do it by your own also.
Yeah, like what Faraz also said last time, I think calm shit down, build shit up again from Greg Lehman. I think that's a really beautiful one, because also with an ankle sprain, you're not going to go immediately into big exercises. You first calm down, let the inflammation process do its work, and then slowly build it up again. And same with acute neck pain, acute back pain. Calm shit down first, and then slowly build it up. And that makes a lot of sense. That is very biological, I would say, um, adhering to the biological processes in the body. And but with chronic pain, that's a totally different thing, because these people have already a long-standing pain, and a lot of different factors are, of course, in play there. And then using manual therapy the whole time, yeah, that could be better. But maybe to create a therapeutic alliance, and also to show, to make a connection, really physical connection with your hands, that can be very beneficial also with some patients. Not all, but with some patients. And I think you have to feel which patients need that, and some patients don't need it, I think.
Yeah.
Because more the sporter, the young sporter type who is doing a lot of, who has more empowerment themselves, yeah, they don't need it so much. They maybe need more exercise or more guidance instead of passive, just later do nothing. But yeah.
Yeah,
I
I
think
think
it's all trends, because there are a lot of trends. Manual therapy was a big trend. Now we see a lot of strength and conditioning. We should only get people stronger, but some people really, in my opinion, don't really need it. They just
Mhm.
have like a painful experience, and then you can help that patient surpass more easily that painful experience, and then he can go and do whatever he like. So, and in essential, I really like a quote from I think it's a very old one, like from the 80s, uh, from George Box. He said, like, essentially all models are wrong, but some are useful. So we can
Mhm.
use from that model this thing, from that model that idea, and we should really have like a patient-centered approach, like to see
Mhm.
what does really this patient need and believe in, because we know that if the patient has really strong beliefs, changing his beliefs takes time,
Yeah.
and this time sometimes maybe you don't have that much time, and to really help him surpass that really painful experience, talking about acute pain episodes, maybe you would use what he believes. Definitely with chronic patients, it can be a way to open a window of opportunity, but then we should really move from passive things, and we should not create the patient dependent on us.
For sure. And when you open the window, you have to be very quick to go through. Yeah.
yeah, yeah. I
What do you
mean,
think for us?
yeah. Well, I just add to that what Bogdan is saying. Well, let's talk about acute pain, obviously, because that's majority of the time when people come and see us. When they're in acute pain, those first 48 hours after an injury, and we try to explain to them that there's not much we can do right now as therapists, apart from maybe give you some advice and guidance, because most of the stuff you'll probably see on Google anyway. You just Google sprain my ankle, what do I do? And we have the police, or we have the new peace and love, an acronym, whatever you want to use. So
Mhm.
my explanation, as you mentioned, Neil, was what do you tell a patient when they come in to see you and say, I can't move my neck to the right, it's been 24 hours. Now, I use another analogy called poking the bear. I don't know whether you've heard of that analogy. So if you put a bear inside a cage and sit there poking him with a stick, he's just going to get more and more angry with you. And eventually he's going to probably eat you. You know what I mean? So
Mhm.
if we can not poke the bear and maybe distract the bear with some other kind of modalities, whether that's education, whether that's reassurance, whether that's, I don't know, exercise, medication, whatever it may be, that bear will generally calm down and leave you alone, and he will mind his own business, and at some point he will get better. So that seems to help my patients initially when they tell me, can you just push me here, or on my back, can you just get into it a little bit? And I'm like, well, what's that going to solve? You're already hypersensitive, you're already in pain. I'm trying to modulate your pain and maybe reduce your pain, and me putting my thumbs into your buttock or my elbow into your buttock is not going to release any pain. It's actually going to inflame you more and make you more angry, just like the bear in the cage analogy. So you mentioned about how to explain to patients about manual therapy. That's one thing I use quite often with my patients, is I'm not going to poke you if you're day one post, upper trap muscle spasm or something, whatever it may be. I'm just not going to poke you. I'm just going to tell you to go away, calm it down.
And there's a little bit like people want to scratch their itch. People want to feel every time. Oh yeah, it's still there. Damn, it's still there. And they want to stretch. Yeah, I still feel it. And that's also creating some kind of sensitization, of course, in the whole nervous system. And
Absolutely.
that's similar to the poke the bear. Yeah, you see that a lot.
Yeah, interesting, really interesting. I mean, Niels, what would you say are your positives or pros about manual therapy? That would be interesting. I'd like to hear your thoughts.
Well, there are for sure some pros. Like you can create a more like a connection with the patient, like a physical connection, and people feel that you care. Also, not only that you hear in your tone, but they feel that you can care. You can show that with your hands. I think some people would disagree, maybe, but that's fine. You can create a sense of competence, that you can feel that the people feel that you have competence in your hands if you have practiced it a lot. Okay, because if you have like intern, or you have of 10 years experience with hands-on, you feel a difference. So you can create a competence feeling. So yeah, your therapeutic alliance also. And the competence creates also a buy-in, because that's also what you need, of course. You have to show that you are a professional, you're a competent professional, so that that person will listen to you and stay with you also. Of course, we are a bit sales people for ourselves and our treatments. Um, um, and that, of course, and because of that transient modality or modulation, it can also increase the feeling of competence. So yeah, there are a lot of pros, I would say. What do you
Interesting.
guys think? And of course, and probably I forgot a few, but that's all what I can muster up now. What do you guys think? Do you have
What do
other
you think?
positives?
Yeah. Then in what I'm thinking all the time is what Farah said, like pain modulation. So you can I use it to tell people, look, this is a painful area, but you see now when I'm doing this technique, whatever, it's you don't feel pain now, so you feel better, and now I'm really moving it. So you should not fear movement.
Mm-hmm.
If we have to better dose it, and these are my words. So this area cannot get so much loading now. I will show you, and maybe I'll give you some advices how to manage the load, and but you should not really fear movement, like I'm moving it now. And this is something that it can be used, because a lot of times people uh, develop what is in the first days, a normal behavior. If you have a big tissue damage, you need protection of it,
Yeah.
but sometimes that protection mechanism really stays with them. Sometimes people are very sensitized, and this painful behavioral this pain behavior um, um, sticks with them for a long time. And manual therapy can really help you help this patient reintegrate and come back to its normal moving behavior, let's say.
Yeah. For us,
Yeah,
what do you think?
yeah, I'd agree with both of you. I think you use the word therapeutic alliance. I think manual therapy does improve therapeutic alliance, but there's also, like I said, other things that can improve therapeutic alliance, which is reassurance and just having a chat with the person and saying, hey, how are you? Tell me about your pain experience, and validate their pain and have a chat with them. But yes, definitely, I think that sort of rapport, trust, loyalty, sense of belonging for the patient is important for buy-in. Absolutely, I agree with that. And yeah, I think there is an element of short-term relief, whether that be psychological, physiological, neurological, whichever word you want to use. There is a little bit of relief for half an hour, 1 hour, 2 hours, one day, depending on what the structures are that could be inflamed or highly sensitized at that time. I guess we've all agreed on the pros. I mean, how about the cons? What do people think on the cons? That would be interesting, because let me give you my list. It's not very big, but it's very specific, I'd say. So I think the cons of manual therapy are, number one, the language we use or therapists use. Number two, it's not specific as what we think it is or what we used to think it was, because of what we were taught in university and all these courses that we've been on and continue to go on actually around the world. It hurts your hands. It certainly hurts my hands.
That's for sure. That's for sure.
It hurts your hands or your thumbs or your elbows. And it's also time consuming. I think time consuming is probably one of those things that we use. We could potentially see more patients in a day if we didn't use too much of a hands-on or manual therapy approach. And yes, we talk about it reduces that self-efficacy of the patient or self-empowerment of the patient. So yeah, I think they're my cons to manual therapy.
That's right. I do think the time you can also use it like 5 or 10 minutes, and manual therapy can also be only the joint manipulations, which is in the 5 minutes you're done, I would say, and then you can introduce exercise already. So it all depends what you do, like half an hour of massage, or do you quickly boop, 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 and then go exercise and do other
Yeah.
stuff, or like 10 minutes massage, that can also be, and then go do exercises. And I would say also with the 10 or 15, 10 minutes massage, you can also have the patient more relaxed. It's less confrontational, that you're not sitting in front of each other, so that person can relax more, can tell you more maybe. And that's also a good one. So yeah, there are always like things how you can change it.
Yeah.
Yeah, for me, the biggest con is that you can really create in the patient, you can really create the patient to become dependent on you and say,
Yeah.
okay, I have to come and you have to give this to me all the time. And you can really, some patients, let's be honest, some people in general, they don't like movement. They're lazy.
For
Okay.
sure.
I don't know in your countries, but in Romania we have a lot of this. Okay, so
No problem.
they'll be like, just okay, I don't care about exercise and stuff like that. And with those patients, education really matters. And this is one of the big cons. Like, I really like those first techniques. Do continue with that. It's okay for me. And this is one big con. And then the other one is that we really know. So we have studies now that they're, I don't know, 20 years old. We had like the McGregor studies that they saw an open MRI, and this is 2001, I think, 2004, and they did an open MRI for the cervical in the PAs on the cervical spine, and they really saw only tissue deformation, and it was from grade 1 to grade 4. So they really went into what in the concept of Maitland says, going into the resistance. But also I think there was another one by Cooling, I think, for the lumbar part, and there also they saw that you just move it as a whole, so you don't really move one structures from the other. And this really can, the other con is that it can really create a bias in your mind as a therapist, that you are moving this around that. We should really go to symptom modification techniques to see them like symptom modifications. And I saw in the chat somebody said that that the hands give you a feedback about tissue reaction and how much to progress. Well, that sometimes it cannot really be so helpful because of the phenomena of convergence. So like in the lumbar spine, you cannot really use palpation because you have so much structures there, and you cannot really say on what structure you are. You'll only get a really big bias from it, in my opinion, to say, okay, now I'm on the quadratus lumborum, or now I'm feeling. I learned that one time, and I really felt it till the point I didn't felt it. I learned palpating the psoas, and when I believed in it, I was really palpating it. But then I really understood that nothing happened. It was only on my mind. So my hands was telling me what I wanted to believe.
Well, that's a good thing that you are aware of your biases and that you. But yeah, sometimes you do feel it, sometimes you don't feel it. It's always a challenge. And expectations is also very important. What a person comes into, if they expect massage or manual therapy and you don't do it, that's a big problem because then they think then you have done everything is clear, and at the last minute they say, "Are we going to do massage?" So that's a very big thing to manage to maybe ask in the beginning, what do you expect from this treatment?
Yeah,
Do
good
you
question.
guys ask that also?
Yeah, generally, obviously, in the first first session, new patient, initial consultation, my first half an hour appointment is usually just gathering a full history, letting the patient speak, telling us their story, and I actually don't really touch the patient at all. I just sort of, and they sometimes people think it's very valuable that somebody listened to their story, and some people think it's actually a waste of time. I'm not coming back to see this guy again because he didn't touch my neck or he didn't touch my knee. So it's patient specific, I guess. And but I've always that's always been my approach. Probably more so in the last, I would say, probably 8 to 9 years, where I've just sat down and said, "Tell me what's going on," and just have a chit chat with them and see what's going on. And then from the second session, yeah, maybe I might do some manual therapy. But again, it's only you, like you said, 5 to 10 minutes or one session of manual therapy, and the next 2 or 3 will be movement-based work. So again, every therapist finds their own, I guess, way to treat these patients. But yes, I would have to say that's my approach to people who come and see me and have their expectations. I don't mind meeting people with expectations, but sometimes they have to understand that therapists know best generally. I mean, patients might know their body, I understand that, but you're coming to me for help, so therefore I'm going to give you some advice. And if you want to listen to my advice, great. If you don't, then you can go to a spa down the road and have your massage from not being disrespectful, but from like a Thai or a Filipino or a Nepali lady. Go for it, no problem at all. I have no problem with that.
Yeah, that's interesting, right? Do you cater to the expectations or what they want, or do you just stick with what you do and then go with um, go with that, and then somebody also sometimes you also have to leave that patient, or that patient goes to somebody else. That's also fine.
Depends if they're paying you 1,000 euros a session.
Yeah.
Yeah, coming. I the problems that I have with the patient's expectation is that they really come to see me after some or maybe one, but sometimes several medical consultations from doctors, and they really have like a biomedical view of it. So they come like, okay, I have a disc L4, L5 hernia to the left, and they just show me them. They show me the MRI and say, okay, doctor said I will receive from you physical therapy. So, and their vision of it is that through what I will do with them from my therapeutic intervention, I will put it back into place. So yeah,
I think.
then yeah.
Sorry, Bogdan. I think that's an absolutely incredible point. And I just want to take that a little bit further, because unfortunately, around the world, with all due respect to general practitioners or orthopedic surgeons or sports medicine doctors, they don't actually know what we may do as a physiotherapist. So sometimes it's their misinterpretation or language that they've used with the patients. Oh, go and see a physiotherapist. You need manual therapy. You need a trigger point release. You need a myofascial release, and you need to put your pelvis back in place. He will do that for you. Thank you very much. Off you go. That also puts our first 1 or 2 sessions almost wasted, because we're trying to unravel all those words and misideologies that the doctors have given that patient before they come and see us. So that was an excellent point. I wanted to just take that a little bit further. No disrespect to any other medical professional, but sometimes people don't understand what we can offer as physiotherapists.
Yeah. And then, yeah, coming to what you said earlier, look, I'm a very big fan of massage, like getting it. You know, I really like it. So, and I explained to the patient, look, this is what massage can provide you. In my opinion, as a specialist, the biggest effect it can be to help you relax, and maybe this can really help you. So if you'll get more relaxed, then definitely you will feel better. So I'm not a big fan of doing like a massage, like the classical one using oil and stuff like that, or creams. But I can say, look, I have good colleagues that do this thing, and if you like it, there is no problem. But I don't really expect that you'll get much better through massage. So you can have it, it can help you, but if you really want to feel better, these are the steps. And the steps that I'm proposing, they're not like the best steps, because we know we don't have really the best approach. We don't have the best results with all patients. We don't have like 100% a guarantee of our work, but these are what we know till this point that works the best. So, and if you do these things, we know that you have more chances not to have another episode, because this is something that some patients have as expectation. They will be like, okay, so I'm doing this with you 8 to 10 sessions, and it will go away forever. And this is something that we should really say, because these patients, I don't think they really hear it from other specialists, that if you have back pain, yeah, it's very possible that it will come again.
Yeah.
For sure. There, somebody else from the team said that he had a lot of cons to say about manual therapy, but yeah, there are a lot of cons, of course, and there are also pros. So yeah, it's all depend. And there's so many physios who are still only massaging. There are so many physios in the world. They are probably not on social media that much, but there are so many physios who only do that.
But there are so many physios that also do a lot of electrotherapy, and only electrotherapy
Yeah.
modalities. There are also a lot that do only manipulations, or there are a lot that only do exercises
Yeah.
and don't explain nothing. So I think that we as specialists, we should just really see how we can really get to that patient, and then use some of our tools, and then from there we can build up the alliance that we are talking about.
Mhm. Joanna said, touch can tap into parasympathetic nervous system influencing emotional response. Yeah, that's very true. Sometimes I've had only I put my hands on and then somebody starts crying. It is for some people they are like run down, they are depressed, they have too much in their life going on, which is not changeable. Because we think now okay, then we have to go make a plan and we change everything. Sometimes it's not possible. Um, you have colleagues, you have a wife, or you have children, or something, or you have other stuff going on, and you cannot change anything. And then I had a patient also who had that, and then I said, okay, let's just she said, actually, I just want you to say I don't have to do anything anymore. That's what she wanted to say. That's how far she was actually. And I said, okay, I had to laugh a little bit, of course, but all right, that's what you need. Because you also have to say, okay, this is what I can say, you need exercise. And I said it also, of course, but slowly but surely, first calms you down and then build it up. And now we're a few sessions later, and now she wants to talk about exercise and stuff. But she first needed to or how do you say, decompress, relax, and somebody was listening to her. Somebody was talking to her, which she probably didn't got at home. And then you go through the whole week not getting these things what you need, and then once a week you get like time for you, and that's also very important, I think. And that this has to do a lot with your emotions, of course, and how you deal with stress. And during that manual therapy, you can also have great conversations and give some tips, maybe how to set your boundaries better with your partner, maybe, or communicate better. You can have put some tips in there. And yeah, you're not Superman. You cannot change everything in one or few sessions. Yeah, and then you can help already somebody a lot with
I
just
can
manual therapy.
I can totally relate with what Joanna said. And every intervention, in my opinion, that we do as specialists, they don't hit only one point. So if you are mobilizing the knee, let's say, it's not that it's only about the knee. It's all the time also effect to that
Sorry, what?
person. When you're mobilizing for, say, like, let's say, a knee, it's like it's not only about the knee. It's the whole. You are working with the person, but also your words or your exercises. The problem, going deep in what she said, that you tap the autonomic nervous system, is that we don't really know how we are doing that, and we cannot replicate, because there are things that say, okay, through manual therapy you can have an emotional release. There are techniques of emotional release and stuff like that, but that's we cannot replicate it. So you cannot use it like to help people, to have it like a specific goal. Okay, I will help this patient with its emotions or with his depression through manual therapy, because you cannot replicate your techniques. But yes, sometimes you may touch a patient that hasn't been touched for a long time in that area, for instance, and that can really trigger a lot of things. But touching another person has different effects. So
Hmm.
um, this is something that it can happen, but in my opinion, we should be very careful if it happens.
For sure. Um, Kathleen, in your opinion, for a physiotherapist who wants to learn manual therapy, how do you choose a course to start with? First of all, you have to ask yourself why you want it, of course, but I think it's a great thing to have as a therapist. What do you guys think?
Go ahead, Bogdan. I'll let you go. I'll let you take this one.
Well, I'm involved in Romania in a program that we know today that there is an international body, so it's the IFOMT, the International
Mhm.
Federation of Orthopedic Manual Therapy, that really tries to get all the concepts together, and really tries to give the direction of what is manual therapy and what is not. So a program that it's iPhone recognized really has to pass some rigorous curriculum and don't teach a
Mhm.
lot of things that they are not true. Definitely, how I said earlier, every concept has its limits. So staying in one concept, it doesn't matter what's the name of the concept, will really limit. So if
Yeah,
you really want to learn, you should try to study all of the concepts if that's possible. But then, yeah, it's up to see when you should use it.
That's for sure. I've done a master's in manual therapy in Holland at the SOMT. That's also an IFOMT related organization. Yeah, the main thing I've learned there, besides the manual therapy techniques, is also the clinical reasoning, and that
Yes.
is super important, of course.
Good.
Knowing the red flags, knowing when not to do it, with which patient you should be doing it, and so yeah, you make some hypothesis. What could be the trigger of this pain? I think that's really interesting. Yeah, and with yeah, you have so much more knowledge around this then about the bio more, but also they touch on the psychosocial factors also, which is a great more
Yeah.
holistic point of
There,
view, I would say.
there are some that from that teach orthopedic manual therapy that they advocacy the idea to change it to the name of musculoskeletal practice, because how you said, we're not an orthopedic manual therapist doesn't really do only hands-on techniques. It has all the process of assessing the hypothesis, creation, testing, and if you in that point consider that you need a technique, you can do it, but all the time you prescribe exercises. So although we have orthopedic manual therapy as a way of defining it, you see we do much more things, exercise and stuff like that.
Hmm.
Yeah, I would just like to add. I mean, I don't think it's just my opinion. Okay, so don't take this the wrong way. I think my opinion is it doesn't matter where you get your manual therapy qualification from. To be honest, but like you said, it's about those critical thinking, clinical reasoning, and communication. The three C's I like to use. If you can keep those at the back of your mind when you are using a manual therapy technique, that will make you a better clinician overall. And as I said in my opening statement, a good physiotherapist is not determined by his hands, so or her hands. So don't get too bogged down about which manual therapy course, which techniques I should be learning, because this is about that much of your actual holistic presentation when you're seeing a patient face to face.
Hmm. The three C's, which are communication.
Communication, critical thinking, and clinical reasoning.
And clinical reasoning and critical thinking, is there a difference between these, or could you
Yeah, I mean,
explain?
clinical reasoning, obviously critical thinking is maybe thinking outside the box rather than just biomedical. Like, there's something wrong here, and okay, let's look at something else. Is there a rheumatological factor going on? Is there an inflammatory marker going on? Is there something else that could be related to psychosocial aspects of the patient? Clinical reasoning, obviously, yes, if I do this technique, I'm going to get this outcome. Or if I do this exercise, I'm looking to improve thoracic extension, for example. So I think those two, yes, are correlated and they can overlap. But ultimately, yes, communication for me is if you have that communication and rapport with the patient, then that's half of the battle.
Hmm.
Yeah,
Yeah,
you can use models from every manual therapy school, but like Faraj said, sometimes patients don't fit in those models.
Mm.
You know, I studied Mackenzie. I'm a C level, and I studied Maitland also. I studied a program from iFont, um, and sometimes you have patients that really fit in those boxes, and it goes very good. But sometimes really patients don't fit in the boxes. And I have a very nice friend from Greece, from Athens. He says that patients destroy concepts. So uh, what he really means with this patients destroy concepts is that all the time you get that patient that really doesn't fit in your derangement, dysfunction, or posture, or in your scene group, end range group, or stuff like that. So yeah, thinking outside the box sometimes it's very helpful. And what I see more about critical thinking is you should always come back to yourself and see, okay, did you provide the best for this patient that you have in front of you? Did you use the best words with him? Did you use the best explanations with him? Also the best technique, and also the best exercise. So we should always come back to us, and know that every one of us, it's submitted to biases. So like having the favorite techniques and stuff like that.
hmm It's always great to evaluate what you could do better. Of course, that's for sure. You
If you
also
have the
don't. You
you
yeah.
have
You if you have the time, for sure. If yeah, some people don't have the time. Indeed, they are so fully booked with 20 pages in a day, they don't have the time for these things. But if you have the time, then that's great. But also, though, you don't have to beat yourself up if things don't go so well. You don't have to be perfect, and sometimes it's out of your control. You can only change some things what's in your control, and that's only what you do, of course, and how you respond to people. But you cannot change also people. Some people are so stubborn in their ways or stuck in their ways. They only think about the biomedical point of view. This is wrong. There's something wrong with me. And some people are like 20, 30 years searching still for like the real cause of that pain. And like, yeah, that's a challenge. These kind of people. I've had a few years ago when I was practicing more. I had a whole agenda of old people from an old manual therapist who retired, and he had a stuck or always like the same stuff. He was checking the leg length, and then okay, we have to do this and this and this, and then he just regardless do everything the same. So he was first checking, but then just everything the same, like first neck, thoracic spine, shoulder, just all the joints, and go again. And then say also, yeah, you shouldn't be lifting something on one hand because otherwise everything what I just put in place goes back again. So you have to be careful and not unload it and stuff. But yeah, I've tried. I was doing my manual therapy masters then, very scientifically evidence based. No, I was ambitious. I wanted to change all these people. Yeah, that is a big problem because all these people, 30 years they came already with him. 30 years they had pain also, but they loved him because he gave them like attention or whatever they wanted, their comfort zone, whatever, a touch. And I didn't do that. I said, exercise, we should be doing exercise and other things. He's not good what he did. Yeah, I didn't see so many of these people again. But some said, okay, let's try something different. But it's only maybe 5 or 10%, and the rest I didn't see anymore. So
the others probably just found another one that
we did the same.
provided what they believed in.
Mm.
So what we were talking earlier, if really a patient believes in that technique it's has a powerful therapeutic placebo in it.
Yeah,
And yeah, sometimes I really liked Lorimor Moisle's comment on something like this. He said, not using, this was 2019, I think, or I was in the UK for his course of Explained Pain, not using placebo in this period where in 2019 was, it's a really big mistake because placebo it's in everything we do,
it's very
but
powerful.
we should not stick only to it to say it doesn't matter what we do, everything is placebo. But we should know that we have a big effect through manual therapy of placebo. But then, if that can really modulate the pain of the patient and help him pass more easily the experience, the painful experience, and then, in my opinion, get him moving, that's something that you can use.
For sure. Yeah, now I'm also a little bit more relaxed about these things. I used to think, oh, this is the best thing, evidence based. I have to do this, otherwise it's not good. And otherwise, I'm not a good therapist. Also, I thought. So I really personalized it. But now I think, okay, this patient want this. All right, who am I to not give it then if that patient really needs it right now? And then you can always bring in what I said before, like tips and tricks, and try to move that patient towards what you think is best.
Yeah. Good.
Yeah,
All right.
you know how I see it. So like as a specialist, a lot of us have our own style in what we like and what we believe in, and then just patients come and you are known for that style, let's say, and patients come to you because they fit in your style. But in my opinion, a really good therapist is the one that adapts his style to the patient in front of him. So not the patient adapts to the therapist adapts to the patient, and that sometimes it's very hard. Huh?
It's very difficult, yeah, for sure. Yeah, because then you have to have a lot of different ways of treating, of course, and a lot of different ways of communicating also. And you have to be some kind of actor maybe, or you have to change your communication with every patient, which is a beautiful thing if you can do that. But yeah, it's also you have to go out of your comfort zone every time and feel awkward a lot. And
You never get bored, that's for certain.
that's for sure.
Yeah.
But for us, you stick with your plan, right?
No. I agree with what Bogdan just said, and the great Peter O'Sullivan also says it, that we should be the patient should not be dancing to our rhythm. We should be dancing to their rhythm, and that's I completely agree. We have to modify. We cannot put anybody in box, and that's why I said last week on the show that I don't like these sort of so-called algorithms and guidelines, because you're putting something inside a box, right? And you can't. There's always going to be someone who's outside that box, and you have to be able to adapt your communication, your language, your skill sets, your whatever your mood to suit that patient. So yeah, I completely agree with what Bogdan said.
Mm-hmm.
I have a question for everyone who's watching. This is maybe to finish off. Does anybody think they can release the psoas muscle? It's one of those classic questions that we see thousands and thousands and thousands of people trying to demonstrate release of the psoas, and then other people saying that you can't get nowhere near it. And would have to say that I'm on the latter side. Can't get anywhere near it. There's too much stuff to get in the way to get to the psoas. So another technique of manual therapy that people have been promoting for years and years and years, just complete nonsense. But it is what it is. It's in there. It's out there. People still do it.
Yeah, I could do it. I could in the past, so 6 years ago. But then after, I don't know, a big party, I just lost it. I don't know
Yeah,
what
there's so many muscles and intestines in front of it. Yeah, it would be amazing if you could do it. But yeah, you can release your abdominals, I think, because that's the first line, of course, and then the psoas is very deep. So I don't think I can do that now, but you can do stretches. You can do great hip flexor stretches, and then also hold, relax, like activate and relax stuff. I feel a difference when I do that within myself. I'm not sure if that's my experience, so that's true then. So, but yeah, I don't do it with myself now, or with other people.
Is there any questions or comments in the box, or just we've been through them already? I think we've done them all. Okay. Good.
Yeah. All right, good, great conversation. Not too controversial, I would say. I think we had a great balanced view, and we will repeat this also because there's so much more to dive deep in, like how to deal with expectations, how to explain things in a different way, how to increase your therapeutic alliance, how to deal with biomedical viewed patient who came from a doctor who they respect. Yeah, these are the challenges.
Next time.
Next time.
All
right.
guys.
Thanks everybody for watching. Thanks for us and Bogdan for helping. Also Dan, but next time we can have the better connection, and we will practice it beforehand.
couldn't talk because he's from Australia, where the most of manual therapy comes from. Australia, New Zealand, all the majority of concepts, besides Kelterborn, who's Swedish, I think, yes, comes from Australia. Yeah, so
that's why it's not working. You see, Australians, it's the cons of manual therapy. It's not working over there as well. All right, guys, have a good weekend. Take care, everybody.
You too. All right, thank you. Bye-bye.
Bye.